Good morning and happy Black History Month. Thank you for joining the Attorney General's convening on Black health and wellness. We will begin momentarily.
Good morning and welcome to the Massachusetts Attorney General's convening on Black health and wellness. What a way to end Black History Month. I'm April English, an Assistant Attorney General, and I serve as Chief of Organization Development and Inclusion at the Attorney General's office. My pronouns are she, her, hers. Thank you all for joining us this morning for what is guaranteed to be an involved discussion on an important set of issues around Black health and wellness. Our esteemed panelists will discuss the history and impact of health disparities and inequities, but also what progress looks like moving forward. As Maya Angelou stated, you may not control all the events that happen to you, but you can decide not to be reduced by them. After our panel discussion, we will then hear from our staff at the Attorney General's office. They will share with you the work being done in the office to help prevent certain social determinants from devastatingly impacting the health and wellness of Black people. We will then open it up for questions, so please feel free to use the Q&A box to post any questions you may have. We've also enabled closed captioning. Please see the 3 dots at the bottom of your screen to view the live transcript, subtitles, and other options. Without further ado, let's hear from our leader, who constantly reminds us that community knows community. And that is exactly what brings us together this morning. Attorney General Maura Healey.
Well, good morning, everyone. And thank you so much, April, for organizing today's convening. Thank you for your continued leadership in making our office fair, more inclusive. You have been a guiding voice for equity, accountability, pushing all of us to do better. Thank you to your team as well, Ash Cantrell, our Organization Development and Inclusion Coordinator, and our entire Diversity, Equity, and Inclusion Committee, who have kept us focused on the racism, injustice, and inequity that affect our communities and our colleagues, always making sure that we are centering our work in the Attorney General's office around the fact that Black lives matter. So welcome and happy Black History Month, everyone. I'm so glad to have you all here for this important conversation. This conversation around this year's theme, Black health and wellness. I'm thrilled that so many people are tuning in this morning for this discussion. I think we can all agree that the imperative for a racial justice perspective, a racial justice lens on health has never been more clear. We're entering the 3rd year of a devastating global pandemic and economic fallout that has disproportionately infected, impacted, and killed Black people. The behavioral health crisis that has surged has our Black residents, including our Black children, bearing the brunt of its harms. Giving birth in this country continues to become more dangerous, especially for Black women. In Massachusetts, Black women are nearly 2 times as likely to die from pregnancy-related causes than white women. 2 times. Black men in Massachusetts died of overdoses in 2020 at a rate nearly 70% higher than the previous year. Research out of Boston Medical Center identified an increase in depression and anxiety among Black children aged 5 to 11. Now, these disparities are not new. They're the result of 400 plus years of oppression that has harmed the health, the well-being, the safety, the economic security of Black people in America. And a racial justice movement has ripped open these centuries-old wounds. The Black community continues to face racism, discrimination, and barriers in all too many aspects of life, including food insecurity, housing, healthcare, environmental justice, education, transportation. I could go on. That means that all of these issues must be part of an equity-focused view of Black health. So in our discussion today, I hope that we can focus in on our progress towards ensuring Black health and wellness, while also taking a close look at the social, environmental, and economic determinants of health that stress and sicken the Black community. Let's get into best practices and a pathway forward too. After our panel discussion this morning, members of my team will speak about the current work being done in our office in the areas of housing, healthcare, and environmental justice to promote Black health. Maeva Bayard, an analyst in our healthcare division who helped to inspire this event with Deputy Division Chief Sandy Walitsky, Trini Gao, an AGO fellow who works in our Civil Rights Division, Amber Villa, head of our Neighborhood Renewal Division, Sasha George, an attorney in our Environmental Protection Division. You'll hear from them. So please stick around for their important presentations. And remember to always use our office as a resource in this work. I'm now honored to introduce our distinguished group of healthcare leaders who are here to join us and lead us in today's conversation. First, I welcome Michael Curry, President and CEO of the Mass League of Community Health Centers. I also welcome Tanya Santos, Assistant Director of the Division of Midwifery and Community Health at Bay State Medical Center. Dr. Valerie Ward, Senior Vice President and Chief Equity and Inclusion Officer at Boston Children's Hospital. And Dr. Charles Anderson, President and CEO at the Dimmock Center. Today, we'll learn more about their extraordinary work in this space and their perspectives on how we can all better support and protect Black health and wellness. And who better to lead this discussion than Emmy Award-winning healthcare journalist and physician, Dr. Malika Marshall. We are so excited to have you with us here today, Dr. Marshall, and we thank you for your important work and the informative news coverage that you've provided throughout this pandemic. Dr. Marshall has been the Health Watch reporter for WBZ TV for over 20 years and is a practicing physician at Mass General Hospital, where she's worked on the front lines caring for patients with COVID-19. A graduate of Harvard College, Dr. Marshall received her medical degree at UCSF School of Medicine. She's the recipient of numerous awards and was named one of Boston's most impactful Black women. Her outstanding healthcare reporting was recognized with the New England Emmy Award. So please join me in welcoming Dr. Marshall, who will kick off today's discussion with our incredible panelists and guests. Thank you for tuning in, and know that we are committed to moving forward and doing this work together. Now I'll hand this over to Dr. Marshall to get us started.
Thank you, Attorney General. First of all, I have to say that the Attorney General and I went to college together, and even though I don't think we really knew each other in college, we reconnected at our 25th reunion a few years ago. I'm sorry, I'm dating us both, but I am so thrilled that you invited me to participate in this discussion today, because they're topics that are dear to my heart. So thank you so much, Attorney General Healy.
Thank you.
Before we get started, I'm sorry, I have to bring us down a little bit before I bring us back up. And that's because I would like to acknowledge some very sad news this morning. Very dear friends of mine and of Dr. Charles Anderson, who I'll introduce in a few minutes. Our friends lost their previously healthy 15-year-old son, Preston, last night after he collapsed at a basketball game 3 weeks ago. And I mention it this morning because I know some of you out there know the Settles family. They are incredibly well known and respected in the community, especially the Black community. Daryl Settles and Dr. Lisa Owens and their beautiful daughter, Taylor, lost a kind, funny, popular, talented, and bright young man last night. And I just want them to know that they are in our thoughts and our prayers this morning, and that we love them. Okay, shake it off. But today is going to be a wonderfully engaging and enlightening morning. And even though today is officially the last day of Black History Month, I want to note how important it is to continue this conversation well past this month. And again, I expect today to be informative and conversational and present us with an opportunity to collectively make change, evaluate policies, and, as we say, act with purpose. As a Black woman and as a physician who practices in an underserved neighborhood outside Boston, I certainly see the impact that health disparities have on Black and Brown communities every day. And like me, I know you're all committed to putting in the work to achieve equality. We're all in very good company today. So let's get started. As April stated, we will begin with a panel discussion, followed by presentations from staff at the Attorney General's office, and we'll close with questions from the audience if we have time. So please add any questions you might have in the Q&A function at the bottom of your screen, and we will get to them at the end of everybody's presentation. I now have the honor of once again introducing today's distinguished panelists. So we start off with Dr. Charles Anderson, who is president and CEO of the Dimmick Center. He's a physician leader, healthcare executive, entrepreneur, and advocate for health equity. And he has served in a wide variety of roles over the past 25 years in the Boston area healthcare community. He's on the Massachusetts Racial Inequities in Maternal Health Commission and the Attorney General's Opioid Recovery and Remediation Fund Advisory Council. And he serves on the boards of Cambridge College, the Boys and Girls Club of Boston, and Beth Israel Deaconess Medical Center. Glad to have you here, Dr. Anderson. I know you as Charles, though.
Thank you.
We also have Tanya Santos. Tanya is the Assistant Director of the Division of Midwifery and Community Education at the Bay State Medical Center. She has worked as a nurse midwife caring for women and families in Springfield and the surrounding area for almost 20 years. Tanya also chairs the Racial Disparities and Health Equity Committee for the OBGYN department at Bay State with the goal of improving maternal and infant outcomes for BIPOC patients through clinical, systemic, and cultural change. Glad to have you here, Tanya. Michael Curry, I'm not sure Michael has joined us yet, but he is on his way, but I'm going to introduce him as though he's here. He is the CEO of the Massachusetts League of Community Health Centers, which serves over 1 million patients throughout the state. Prior to that, Michael worked for 16 years at Blue Cross Blue Shield of Massachusetts and has served on the healthcare transition teams for former Massachusetts Governor Deval Patrick and former Boston Mayor Marty Walsh. Michael is the past president of the NAACP Boston branch and has over 20 years of dedicated service to the NAACP at the city, state, and national levels. Currently, Michael serves on the City of Boston's COVID-19 Health Inequities Task Force and the Massachusetts Public Health Association's Task Force on Coronavirus and Equity. I don't think he's here yet, but he will be with, oh, he's there. I see you. I'm sorry I didn't have the gallery view. I'm so glad you made it. He literally just flew in and like ran into his office. So we're so glad you made it.
Thank you.
And then we have Dr. Valerie Ward. Dr. Ward is the Senior Vice President and Chief Equity and Inclusion Officer at Boston Children's Hospital, where she's also a pediatric radiologist. Dr. Ward also serves as an assistant professor of radiology at Harvard Medical School. Her primary research has been focused on pediatric health services and child health outcomes, particularly as it applies to patient satisfaction and healthcare disparities. She has received awards from the Radiological Society of North America and the Society for Pediatric Radiology, as well as the Harvard Medical School Minority Faculty Development Program Bridge Award. Welcome, Dr. Ward.
Thank you very much.
You guys have such great credentials. So we're so thrilled that you took time out of your Monday morning to spend it with us. So what I'm going to do is I'm just going to pepper you with questions, but I really want this to be sort of a fireside chat, even though it's morning time. So feel free to speak to one another. You don't have to wait for me. So Dr. Anderson, if you have something you want to say to Michael or to Tanya, just jump right on in. It should be a very casual conversation, and we sort of all know what the goal is this morning. But Dr. Anderson, Charles, I'm going to start with you first, if you don't mind. And I'd like to know, you are a community health leader in Roxbury, and I want to know what conditions you see that you think have the most negative impact on your Black patients and how you think these conditions could be improved.
You know, there's multiple ways to answer that. First of all, I'd like to thank you for this opportunity to have this discussion, because I think it's such an important discussion. Again, I was starting with, there's multiple ways to answer this. One way, we could talk about the chronic conditions that exist in our community. We could talk about the impact of hypertension, diabetes. We could talk about delayed and deferred care when it comes to cancer. We could talk about the disparities in outcomes for women with breast cancer who are given the same drugs, but because of us not having the opportunity to participate in those clinical trials in the same way, those drugs not being as effective. we could talk about those things, but you know what? A lot of what I'm seeing us at a point in time where the house is falling apart and people are trying to rebuild coming out of this pandemic. And what I'm very concerned about in terms of what I'm seeing is that the type of scaffolding that's available for our community is very different than the type of scaffolding that other communities have as we're rebuilding. So I'm seeing people coming in saying, look, I've gone through a tremendous amount of trauma over the last couple of years that have just exacerbated so much of what I was dealing with prior to this pandemic. And I need better scaffolding. I need better supports. I need better coordination of care. I need a system that's going to look at me and understand where I am at this point in time and make adjustments to get to what true equity really is supposed to be about. So with that said, hopefully that answers your question. Maybe it introduces other questions, but it seemed like a good way to kick us off.
Maybe you can talk a little bit about specifics. Are you seeing mostly mental health conditions that are exacerbated, heart disease, diabetes? Can you tick off some of those things that we need additional scaffolding to be able to provide these patients so that they can get back up to at least the point they were before the pandemic?
Absolutely. A big one is mental health. I could talk about the others, but a lot of what we're seeing is a lot of increased demand and need for mental health services. And the challenge with mental health is that it impacts everything else, doesn't it? Right? It really, really does. The shortage of providers that have the type of, and it goes beyond cultural competency. It's really about having that interaction with someone about something that is as sensitive as mental health, where it really benefits to be talking to someone who has a shared life experience, at least by the fact that they have, shared race and ethnicity. And the shortage of providers in general, and especially mental health providers of color, is a real challenge. But let's talk about the scaffolding that people are looking for. They're looking for these services to be integrated. The opportunity to make sure that at that visit, you're able to address those things as opposed to, look, we're going to schedule you to come back in 2 weeks, or we're going to give you this referral there. Part of the scaffolding is that has to be integrated and coordinated. And that is what we're seeing, a demand for that type of service, especially with our young people,
Thank you, Charles. Tanya, I'm going to switch over to you. And I think it was just this past weekend that I saw that once again, US maternal infant mortality rates have gotten worse with the pandemic. And of course, who are they worst amongst? Black and brown people. So please tell me, what concerns do you hear from your Black patients in particular about concerns they have with pregnancy and giving birth and everything related to that?
Thank you. So patients come to me with lots of fears around pregnancy. What we think of for many people that should be a time of joy, for lots of birthers, there's an elephant in the room. Patients have heard the media coverage that we just talked about, that we've heard, that Black birthers are 2 to 3 times more likely to die during the pregnancy period, pregnancy and postpartum, that Black babies are 2 times more likely to die. And that's largely driven by what happens in the prenatal period, like preterm birth. So the media exposure mirrors lived experience. People come to me with concerns about their safety in pregnancy, their baby's safety and survival in pregnancy. They worry about not being listened to, their concerns being dismissed. People are worried about how they're going to be treated in the hospital, how their support people will be treated in the hospital. Healthcare exists in a place right now where self-advocacy is treated differently often based on the color of your skin. And we know that healthcare doesn't exist in a vacuum, that we are a microcosm of the society that we are a part of. We have the same systemic and structural injustices in healthcare that exist outside of healthcare. We're not an objective environment, no matter how much we try to believe that we are. So those are some of the fears that people come to me with. I try to treat each patient as an individual and talk about what they are afraid of, addressing the elephant in the room. People are worried about the impact that racism is going to have on their experience and their outcomes, their lives and their babies' lives. I encourage patients to advocate for themselves. First and foremost, find a provider that they trust. Many patients come to me asking if they can see providers of color. And while I can't provide that, my practice can't provide that for everyone. I talk to them about the things that we're doing at Bay State to help keep them safe. I tell patients if they don't feel heard to say as much, to know what their options are and to ask questions. Everyone deserves to have their healthcare partners explain things in language that they understand, in languages that they understand. I encourage birth plans and support people for times when you're going to be less able to advocate for yourselves. For example, when you're in pain in labor, have your family and family of choice around you to advocate for you when you're less able to advocate for yourself, and doulas for people in labor. All of that's become more challenging because of the pandemic and limitations on visitors. But those are some of the things that I counsel my patients around.
Let me ask you, in your experience being in and out of the hospital with some of your patients, do you think that their fears of being treated differently in the hospital are irrational, or are you seeing firsthand that they are treated differently than other patients who are admitted?
I don't think they're irrational fears. And, even personally, I have hesitations at times for advocating for myself, or when I go to advocate for myself, I know that I'm probably more cautious than someone who's not a person of color about tone of voice and volume of voice and things like that. So I don't think it's irrational.
Yeah, and it's such a vulnerable time. I mean, I had 3 babies, and you never feel more vulnerable than when you're there at the mercy of the people taking care of you and helping you deliver a healthy baby. Thank you for that, Tanya. Michael Curry, I'm coming to you. So tell me a little bit about the origins of the community health center movement and how it relates to civil rights and economic empowerment.
Yeah, thank you. And good morning to everyone. As you said, I just jumped off of a flight and ran into this conference room. So I'm glad that I made it in time to join this conversation. And I want to, Doctor, echo what you said. Daryl Settles is a good friend of mine. So I want to send my condolences to the Settles family as we've all been grieving as they've gone through what they've had to deal with in the last month. So we'll be there for Daryl and his family in the coming weeks and months. It's interesting. I jumped off of a flight a few minutes ago coming from the NAACP Image Awards, of course, celebrating Black excellence, Black history, Black culture. And as we have this conversation today on the closing hours of Black History Month, it's always good to sort of ground ourselves in this movement around primary care, health equity. And I think about the birth of community health centers, those Black activist doctors and physicians and public health folks across the country who their visionary leadership in the 1960s decided that we were trying to integrate lunch counters and desegregate schools. But where we really needed to focus as well was on healthcare, as many of our hospital systems across the country, and particularly in the South, were still segregated through the early to mid part of the 1960s. The backdrop of that period was the work of Martin Luther King and many other civil rights activists of the modern civil rights movement. You had President Johnson's The Great Society at play. You had the historic passage of Medicare and Medicaid, which more and more people now start to recognize as civil rights bills because they helped to desegregate our hospitals across the country. The creation of the Office of Economic Opportunity, which created a lot of the platform on which to build community health centers. And then just understanding where we were during that period of time: high unemployment, high rates of morbidity, mortality, particularly in the communities that we talk about and that we are addressing today. And folks like Jack Geiger, Count Gibson, these physicians out of Tufts Medical School, had seen a model of community health in South Africa and decided they wanted to bring that model back and address health inequity in communities like Columbia Point, where my family grew up, and in Mount Bayou, Mississippi. So 1995, the first community health center opened in Columbia Point. In 1966, where Representative Russell Holmes is from. Mount Bayou, Mississippi was the second community health centers. If anyone on this call has never seen, and this is homework, doctor, I'm gonna give folks that are on this call, there's a 20-minute video called Out in the Rural. You can Google it and it features the birth of the health center movement. What you'll take from that video is this, and I've said this publicly, we were born for a moment such as this. Jack Geiger, Count Gibson, Dr. Hatch, Dr. Smith in Mississippi understood that communities like the ones we're talking about are vulnerable, and whether it's a pandemic, a natural disaster, or these other diseases that we're talking about today, those communities are disparately impacted, and community health centers were introduced as a way to address that. So, Doctor, it is a blessing to be here with Dr. Anderson, to be representing 52 organizations across the Commonwealth, over 1 million patients, operating out of 300 practice sites, and quite frankly, still the tip of the spear as we try to address this pandemic.
Thank you, Michael. I'm going to come back to you because I have another follow-up question that I definitely want to get to with you, but I'm going to move on to Dr. Ward right now. Dr. Ward, your pediatric patients, your children, what sort of disparities are perhaps unique to them as little people who haven't grown up to be adults yet?
Well, thank you. Thank you for the opportunity to share about the work that we're doing at Boston Children's to address that very question. We know that children are a part of a family unit. And so we don't only look at the child, we look at the parents, we look at the family, we look at the community. As an anchor institution, there is a responsibility. I like hearing what Michael Curry and Dr. Anderson have said about the community movement, but there is also a role and responsibility for the health system, for the hospital that is an anchor in the community to serve in pediatric health equity. For example, at Boston Children's, we recently created in 2021 an institute dedicated to pediatric health inequity and inclusion. And so what is that? What does that mean for our children? It means that we're going to be intentional in prioritizing health inequities that children experience. And what they experience is multifactorial. It's at the level of the child. It's also at the level of the parent. It's at the level of economic disparity and educational attainment, differential educational attainment. So where I'd like to go with this is say, we are focusing on what are the opportunities that the anchor institution can make? What can we do? Can we provide jobs in the community? Yes, we can. As a health system, we have resources. We can also bring the community into our hospital and say to children in elementary, high school, and college levels, look at the vast array of careers we can expose you to. With that, we can hire you and eventually have more healthcare providers that look like the communities we serve. So Dr. Anderson has already touched on the fact that we need more diverse doctors, nurses, respiratory therapists, X-ray technologists. I could go on maybe about 43 different job descriptions off the top of my head that children don't even know that they can aspire to become. Some say you can't be what you cannot see. Well, let's show them. The responsibility of the anchor institution is to say, this vast array of career opportunities exists. We want to train you. We want to start at an early age because we know that pipeline, that pathway to economic stability, it begins in elementary school, maybe even preschool. And it continues through high school opportunities, college opportunities. And then we want to hire individuals from the community to come and work and care for our patients. The reason being is we know that patient adherence to treatment recommendations, to whatever therapies, whatever their doctors say, we've already heard, very much linked to, does my care provider look like me? Do they speak my language? Do they understand where I'm from? So we're very interested in being intentional in the work, in connecting our patients with our health system. And the responsibility lies on the health system with the resources. So thank you.
Thank you, Dr. Ward. So I like this concept of you can't be what you cannot see. And I'm just wondering practically, how does that work? Are you exposing children that you see for their primary care visits, for their annual checkups? Are you talking to them about opportunities in the health system? Are you talking about going into preschools and elementary schools to sort of talk to kids about opportunities in health? How do you practically see that playing out?
Oh, sure. we've been very intentional in the work. We are bringing high school age children, college, youth, I shouldn't call them children, young adults, into the hospital. Of course, the COVID pandemic limited the ability. We had them on the premises, but then with COVID, we took them to telehealth and we took them to virtual Zoom platforms. We are showing them the jobs. We're having professionals, all types of medical professionals talk to them. And we're also mentoring, and we're doing longitudinal mentorship. It's not just I'll meet with you for a few months. It's like, I'm going to stay with you as you go through your educational process. We are not so busy to do this. We've all had mentors along the way, and it's the longitudinal relationship. So yes, when conditions permit, we'll bring the children back in and the youth back in. Right now, we've got a school vacation week program for April School Vacation Week for area high school students to come and hear from our different healthcare providers about their profession, what they like about it, how they got to where they are, and really to show our youth that we are ordinary people who just stayed on the path. There's nothing special about what we've attained and what we do. They can do it also. I believe that's a practical approach.
And how would people find out about that if they had friends or family or themselves want to sort of connect their young people with them?
Oh, sure. They can go on our website at Boston Children's, and we've got some of our programs listed there. They can also reach out to our health equity at childrens.harvard.edu mailbox and ask, and we'll provide information. And also they can reach out to our human services department. Our human resources department has a workforce department within it that has other programs I haven't even mentioned here. So it's rich. Knowledge is key. And there's a rich amount of information, but if you don't know that it exists, you cannot partake in it.
Thank you, Dr. Ward. I'm not being selfish. I'm encouraging everybody out there to put their questions into the Q&A feature. We have a couple of questions that have come through, but before I get to those, I just wanted to follow up with Michael Curry. This question about the Black tax, sort of the need to go above and beyond to prove one's worthiness. And statements like, you have to work twice as hard to get half as far, are often drilled into the minds of Black children. I know my parents told me that the entire time I was growing up. And so our question to you is, how do we combat these views and sort of teach Black children to prioritize their well-being and not feel the pressures to go above and beyond what some of their non-Black peers are doing?
Yeah, I think it's such an important question. And of course, in the last 2 years, I think many have had an epiphany around many of these issues. We've started to talk more about racial justice and health equity, the challenges of being African-American and many other people of color trying to navigate systems that weren't always, and in many cases, designed for us to thrive and succeed. And I know it's so funny, Doctor, I posted on my social media page, I'm glad so many people are woke and others are waking up. But some of us, like those on this call, are insomniacs, right? We can't sleep because we see it. We pay attention to where those inequities lies. And one of the places is the fact that if you are African-American, I think about this even as we talk about a Supreme Court nominee right now, and an African-American woman, and the scrutiny that we can almost guarantee she will go through to be confirmed. It is a society that doesn't value our expertise, our brilliance, our excellence. We see it in theater, we see it in the medical profession, we see it in the legal profession. It is up to us to challenge it everywhere it exists. I was introduced to that concept of the Black tax when I was a college student at McAllister St. Paul, Minnesota. By a professor who said, when you walk into the room, there's a tax that you're going to have to pay that many other people don't have to pay. And sometimes society will levy that tax on you, and sometimes you will levy that tax on your own self, right? You'll feel like you need to do better than, you'll need to get 3 degrees just to compete with those who may have 1. The reality is it can cause burnout. We've seen it even in the medical profession as we've been talking this morning about creating a pipeline, a robust pipeline of Black and brown physicians. I think of Rebecca Lee Crumpler, doctor, the first African-American woman physician of the 19th century who had sage advice for all of us. She said, they seem to forget there's a cause for every ailment and that it may be in their power to remove it. Way before social determinants of health, way before Jack Geiger and Count Gibson lost the community health center movement. So we need to address this issue. How do we make sure that if you are a Black girl, I think Kizzmekia Corbett, who helped find the Moderna vaccine. And I tell people there's a little Black girl sitting in Southside Chicago on Roxbury, right outside of Dimick's Health Center in the community, who's meant to find a cure for cancer, but we may never know her. We may never know her because she doesn't have the academic support or the rigor, the social support, or she's internalized racism. So we have a challenge. We have a lot of work to do to dismantle, even in our own psyche, how racism manifests all around us.
Thank you. And I'm glad you brought up Judge Ketanji Brown Jackson, who also graduated in the same class with me and the Attorney General. So we're in good company. And of course, as soon as her name was raised, I know we're so proud of her and I know her personally, and she's every bit as capable as they say she is. But of course, immediately, as soon as her name was brought up, they, I don't know, like she might not be qualified. Like there is nobody better qualified to fill those shoes, in my opinion, than Judge Brown Jackson. So we have a couple of questions that are coming in from the audience, so I want to make sure to address those, and whoever feels most sort of prepared to answer them can go ahead and jump in. We have a question from Arthur Edwards, who says, how can we engage our community leaders and advocates to address health disparities if we don't live in vulnerable communities?
I'd like to start with that one.
Please.
So it doesn't matter where you're from. If you are a part of a health system, again, I'm going to bring it back to the big health system in the community. You may not be from a vulnerable community. Many of our doctors in the health system want to help communities that they don't live in. So what we do is we work on ourselves in the hospital. We want our providers to have implicit bias training. How are we treating people when they come to the doors of our hospital? We don't want our patients from vulnerable communities, marginalized communities, to feel uncomfortable within our hospital. You know, do we say that is an asthmatic kid, or do we say that is a child with asthma? Do we say that is a problem child, or do we say that is a child who has behavioral problems? How do we talk about our patients? And that's why training in patient-centered care and focusing on access. If you're not from a vulnerable or marginalized or underserved community, you can think about, can I mentor someone? Can I show a group of youth what I do? Bring them in and just see a day in the life of what I do, how I got there. Again, being practical and intentional. And the other thing I like to think about, and I'll stop with this one, is do we ask individuals in those communities, how best can our health system serve you? And what barriers are we putting up in front of patients and families that try to access us? Because I believe access to excellent care, access to subspecialty care is the root of many of the health inequities for children. So thank you.
Thank you, Dr. Ward.
I would love to add to that, because I think it's really important to understand a lesson that I learned when, collecting all those multiple degrees to deal with the Black tax. When I did my master's in public health, there was a course I did on community learning and teaching. And it's that ability to get into community with an open mind to learn first. I spent time at a school for pregnant teenagers called the Paquin School in Baltimore. And I learned that valuable lesson about how critical it is to listen. The more we listen, the more we learn. The more we learn, the better we are. And I think that is an important part. We all have ears. If we're willing to put ourselves in that position to really listen, that's how we all can show up and make change.
Thank you, Dr. Anderson. I have a question here specifically for Michael Curry. Jack Geiger and other founders of the Community Health Center movement saw CHCs as contributing value far beyond the delivery of healthcare, including showing Black and brown children that people who looked like them were skilled physicians, nurses, etc. That Dr. Ward touched on this. And addressing not just the effects of financial poverty on health, but also what Jack called the, quote, poverty of imagination or dreams of our Black and brown children, what they have to live with. So the question is, can you paint for us a broader appreciation of the ways in which DMIC and other CHCs are vital community building forces?
Yeah, so I think it's an excellent question. And, I think about a few different things. So one, a good friend of mine, a good friend of ours, many of us on this call, Ayanna Pressley, Congressman Pressley, says those closest to the pain should be closest to the power. She really spoke to what Jack Geiger and Count Gibson and the rest of them, Dr. Smith, those Black physicians across the country, helped create in a community health center movement. And part of that was they made sure that half the board, over half the board, had to be consumer board members of the health center. That doesn't exist in too many other spaces, where the people actually sitting at the table closest to the power are those people who come out of those communities who are dealing with higher rates of morbidity, mortality, shorter life expectancy, and are dealing with the circumstances, that 80% that doesn't deal with the care that many of you provide when a patient comes to see you, but that 80% upstream, as Bishop Desmond Tutu, the late Bishop Desmond Tutu said, let's go upstream and pull them out of the water before they come downstream. So the reality is Jack Geiger, Count Gibson, the rest of them, they understood that it was about getting you clean water. It was about getting you food, Dr. Anderson. It was about making sure that you had stable housing and that you had an economic opportunity, a job, so that you can bring some wealth building back to your family. Health centers are still doing that here and across the country, as Dr. Anderson knows that the work that he does to provide care, eyes, teeth, mental health, substance use disorder. We also have the honor and the opportunity to lean in other ways that are not just about care. And we're still engaged in this issue of social determinants of health, and we are providing food vouchers. We are meeting people to get the services that they need more broadly than what health centers directly provide. That is an excellent question. And we are even stepping up our efforts in the wake of the last 2 years to figure out how we can do more upstream as well.
And I have to add to that, specifically as it applies to the Dimick Center, because part of the vision was just that, Michael. It was paying attention to the broad range of requirements to meet all of these different determinants, to give everyone that similar access to an opportunity to thrive and to be well. On a campus like ours, not only do we have the traditional health center services, again, we're celebrating our 160th anniversary where we were a hospital even, but we also have Head Start, early Head Start. We're dealing with educational equity on our campus. We have a shelter, one of the few shelters for families on our 9-acre campus, not to mention the inpatient work we do in terms of detox, clinical stabilization, supporting those with substance use disorders. And we're the largest employer in Roxbury. This is exactly what the movement was about, and it's exemplified on a campus like ours.
Here's a related question from Kershell Floyd, who wrote, Dr. Curry, I heard how proud you are of community health centers. What are we doing or plan to do to change the stigma or community health center being for uninsured and underprivileged persons? What is being done for these locations to not be left with the scraps, leftover equipment, limited staff, uncared for infrastructure? Either one of you.
Well, I think first and foremost, I'm not Dr. Curry. I got in the other line, which is the lawyer line, but honored that somebody would call me that. And honored to be here with real doctors who do this work and quite frankly are on the front lines of saving us, particularly in the last 2 years. If we didn't appreciate what you all do, the last 2 years should have made us all aware of the importance of our healthcare workers. That being said, I totally agree. Part of it is we thought under health reform, 2005, 2006, we knew in the health center movement, Dr. Anderson, that people wanted to come to health centers, that people travel to health centers. We serve 97% of the zip codes in the Commonwealth. I want you to picture the state of Massachusetts, 97% of the zip codes. People are driving from rural areas to a community health center to get their care. Some people thought in 2005, 2006, when we expanded healthcare in Massachusetts, that people would walk. They would go to other settings, private primary care practices to get their care. That's not what happened. Our movement grew because people knew that we provide quality, accessible healthcare. And quite frankly, to what everyone said today, you walk into a health center and you see Dr. Anderson that reflects your community, your lived experiences. You can walk into a health center and see a Honduran, a Russian, go down the list, a community health worker, a nurse, a medical assistant. That's what this movement was all about of community health centers, that we reflect the communities we serve. We serve close to 70% of our patients, people of color. That's why we did the contact tracing. That's why we did the testing. That's why we were on the front lines of getting the vaccines out. So the reality is we have a story to tell that quite frankly is drawing more and more people into getting their care. And so many people, mayors, town managers, elected officials come to me all the time, say, Mike, I still get my care at my health center, as Dr. Anderson would attest to.
Thank you. We only have a few more minutes left for questions, and I want Tanya to be able to jump in here. Tanya, you have a question that's been specifically addressed to you. What are some examples of cultivating an inclusive environment in healthcare that help improve patient outcomes?
Thank you. Well, we can't make our healthcare institutions safe for Black and brown birthers and babies without addressing the implicit bias in our healthcare systems. So I think at the institutional level, like at Bay State, we're doing implicit bias training for all of our labor and delivery inpatient, outpatient staff in the Department of OB-GYN, and really taking the view that in order to make our healthcare institutions safe, we need to own and address our own implicit bias and the impact it has on the care that we provide.
Did anybody else want to jump in on that question?
Yeah, I mean, I think part of that inclusivity is it does start with the work that we do inside our institutions and with all of us who are providing care. But I think the other thing we have the real opportunity to do is to constantly support the type of advocacy to make sure that communities also understand that they can have demands of us, right? That they can stand up and say, I'm not going to accept a care experience that does not line up with my expectations. So there's a lot of empowering and strengthening community that we do as well. So it happens internally in terms of strengthening our staff's ability to meet those needs, but also tapping into the community to make sure the community is holding us accountable.
Right. And in our last minute, I think this is an important question, and Tanya, maybe you can tackle it first. What can allies do to push for more equity in healthcare as colleagues, as patients, and as peers?
Well, I think part of it is this conversation that we're having today is raising these issues, the issues of Black health and wellness, and realizing that it extends outside the exam room, the health center, the hospital, and they are issues not just for the Black community, but for all of us to tackle. I think in terms of healthcare policy, we need to have policies that focus on creating a diverse workforce, like Dr. Ward mentioned, and creating that from our communities so that we're uplifting the communities that we serve at the same time that we're building a diverse workforce. And we need policies that support collection of useful data along race, language, ethnicity, sexual orientation, gender identity, disability status, so that we have the data to make the decisions to drive our health equity work.
And maybe Doctor, just 15 seconds, which is, I love this concept of the weathering effect, that we've been weathered to higher rates of more morbidity and mortality. We've been weathered to higher rates of asthma and heart disease and cancer and the different areas of cancer. We need to unweather ourselves. That's where allies can lean in, right? Be impatient with the inequity that exists in healthcare. Speak up wherever you are, whether you're a policymaker or you're at a healthcare institution, and say, well, what are we doing to make sure that we resource those community in an equitable way? I'm seeing it now more than ever. We have more Black and Latinx leaders in healthcare in Massachusetts than we've ever seen in Massachusetts. 0.32 children, you go across the systems. We need to seize that opportunity like they did in 2005 and 2006, and make this into a movement around health equity.
Thank you. Well, of course, we could talk about this for another 30 minutes easily, and there were a number of questions, unfortunately, from the audience that we didn't get to. So I'm hoping that those who did not get their questions answered can reach out directly to the people that they want answers from. I'm sure all four of these wonderful panelists are accessible to you. So we can, I'm sure the Attorney General's office can get their contact information to you if you want any other questions answered. But right now, we are going to move on to hearing from the staff of the Attorney General's office, all instrumental in putting together today's event to discuss how her office has been a partner in this work to promote Black health and wellness. So first, we are going to hear healthcare analyst, I want to get this right now, Maeva Bayard, who will discuss the inequities of the opioid epidemic and barriers to care for diverse patients. Maeva.
Thank you, Dr. Marshall. Good morning. My name is Maeva Bayard, and I'm a healthcare analyst in the healthcare division. The Attorney General's healthcare division works to promote public health and improve the efficiency and effectiveness of the healthcare system in Massachusetts. That's important as we've seen a long-standing disparity and toll that the COVID-19 pandemic took on Black people in Massachusetts. I'm going to speak about the office's recent work relating to the opioid epidemic, which is still ravaging our state and is disproportionately harming Black people. Systemic issues, including healthcare provider biases, limited public health research, and inadequate news coverage, have mischaracterized the opioid epidemic as chiefly impacting white suburban rural communities. However, Black communities are increasingly affected by opioid use disorder. In 2020, as a nation, we reached the highest number of fatal drug overdoses, 93,000, with a disproportionate number of that population being Black and Hispanic people. Massachusetts DPH data shows that overdose deaths increased by almost 70% among Black men in 2020. Treatment inequities and devastatingly high mortality rates within the Black community require recovery services that are diverse and not one size fits all. A recent report by the Substance Abuse and Mental Health Services Administration reveals that Black people have substantially lower access to behavioral health and substance use treatment services and often experience less culturally responsive care. Racial equity is a critical component of combating the opioid epidemic. It's why we created a grant program dedicated to improving cultural humility and substance use disorder, helping to remove barriers to care that have systemically and disproportionately harmed Black people for far too long. And it's about removing the stigma around asking for help. The grant program, titled Providing Cultural Humility in Opioid Use Disorder Treatment, supports treatment and recovery programs committed to standards that serve Black, Indigenous, and people of color in Massachusetts, and organizations that are committed to providing accessible recovery and treatment services to diverse patients across our state. It prioritizes innovative solutions and applications that demonstrate an understanding of providers' biases and barriers to care. For example, the Massachusetts Organization for Addiction Recovery is using this funding to increase access to BIPOC communities to recovery coaching, with a focus on services for pregnant or parenting women, veterans, and recently incarcerated individuals who are actively engaged in treatment. And Boston Medical Center is using grant funds to support mothers and babies with trauma-informed services and culturally sensitive practices in treatment for mothers with opioid use disorder. The funds will also be used to provide critical support to infants born with neonatal withdrawal syndrome and assist new mothers with the challenges of caring for newborns who are experiencing withdrawal. It has been a priority of this office to combat the opioid epidemic through a multidisciplinary approach that includes equity, enforcement, policy, prevention, and education efforts. In June 2018, A.G. Healy was the first state attorney general to sue members of the Sackler family, the owners of Purdue Pharma, for their role in creating and fueling the opioid crisis. Last summer, a resolution of that lawsuit was announced that would dissolve Purdue, disclose their documents, and deliver billions of dollars for families and for treatment. We have committed that any recoveries we receive through litigation and settlement efforts like these will go to our state's new Opioid Recovery Trust Fund and Advisory Council that Dr. Anderson is thankfully a part of. This was one of the first laws in the nation that ensures that opioid settlement funds go to address the opioid crisis. Our office is already bringing in hundreds of millions of dollars to Massachusetts to be spent with input from families, communities, and public health experts to save lives. For example, $10 million for Massachusetts from our multi-state settlement with McKinsey & Company over claims that advised Purdue on how to target doctors to turbocharge OxyContin sales. and more than $500 million from a nationwide deal with opioid distributors and Johnson & Johnson. It is public health crises like the opioid epidemic that our office works tirelessly to address. In the fall of 2020, we published a health equity report with policy recommendations to advance racial justice in healthcare in domains including healthcare data, healthcare workforce development and diversity, and equitable financing for healthcare services. Promoting health equity is a priority for the healthcare division. We will continue to seek opportunities to dismantle systems of oppression in healthcare, while also finding ways to promote the well-being of the healthcare system of Massachusetts.
Thank you, Maeva. That was perfect. We're going to hear from 3 more staff members with 3 more presentations, and then we're going to open it up for questions of them. But then you're also going to have an opportunity to ask a couple more questions of our panelists. So continue to put questions in the Q&A. And again, if we can't get to your question, we will try to put you in contact with the people that you're interested in speaking to afterwards, but keep the questions going. All right, so now we'd like to welcome Trini Gao, who's an AGO fellow who worked in the AG's Civil Rights Division, to discuss the housing crisis in Massachusetts and conditions that exacerbate disparities in low income and Black communities. Trini.
Thank you, Dr. Marshall. So the Civil Rights Division has been working to identify housing providers in both the private market as well as subsidized or public housing to address housing conditions that exacerbate disparities and inequities in low-income communities of color. In particular, we focus on bad air quality, which can be caused by things like mold, mildew, and pests, and can exacerbate asthma and other illnesses that disproportionately impact low-income Black and Latinx families. This work lies at the office's intersection of our disability rights work, our racial justice work, our economic justice work, environmental justice work, and health equity work. The Civil Rights Division recently resolved a case involving the Boston Housing Authority, which is a public housing authority which provides housing to nearly 19,000 residents. Most of BHA's residents fall into a category labeled extremely low income, and many are people of color. A significant portion of them also have disabilities. This case highlighted for us systemic issues in the public housing system, such as how a lack of funding and resources for public housing has resulted in systemic level bad air quality and other environmental conditions, as well as the fact that public housing authorities such as BHA are in various ways failing to adhere to their legal obligation to accommodate people with disabilities. This particular case involved a family of 3, 2 adults and their child. They had previously experienced homelessness and housing instability and were on the BHA waitlist for many years for a housing unit before they were finally taken off and assigned to a housing unit at BHA's Old Colony development. So the family's building in which their unit was located is one of BHA's oldest and most historically distressed developments. BHA itself determined in 2009 that the deficiencies of the property were far too severe and numerous to be rehabilitated and was compromising the health and well-being of its residents. And they began a redevelopment project shortly after. However, that project had not yet reached the family's building. So BHA had determined 8 years prior to assigning the family this unit that the conditions in the unit and in this building were would have a detrimental effect on the residents' health. So it didn't take long before the poor environmental conditions began to have a severely detrimental effect on the family's health. The son had significant pre-existing health issues, which were exacerbated by the conditions, which included a persistent mice and cockroach infestation, dust, black mold, and the family was also unable to control the temperature of their radiator. So in 2018, the family first requested a reasonable accommodation transfer to a unit without the conditions that were exacerbating their son's health conditions. However, BHA failed to respond to this request, and the family made repeated requests over the next 2.5 years to no avail. So it was apparent to us from this case that a lack of funding for public housing, high demand and low supply of available and habitable public housing units, staffing turnover and vacancies, burnout, lack of training on reasonable accommodation protocols meant that BHA was failing to adhere to its own reasonable accommodation guidelines and improperly denying tenants accommodation requests without even attempting to work with the tenants or letting their applications sit for months on end without follow-up. So the resolution in this case involved a payment to the family of up to $55,000 and a transfer as soon as possible or by the latest July 2021 to the unit that met all of their health needs, as well as widespread protocol changes for processing reasonable accommodation transfer requests. This included broadly training on their policy for all current and new employees, prompt responses to transfer requests, diligent tracking of communications with the tenants, and interactive dialogue protocols with tenants throughout the entire process, from submission of the application to ultimately to the decision by BHA whether to transfer the tenant or not. So in closing, while this family ultimately was able to access healthier living accommodations and broad reforms were enacted at BHA to ensure that tenants with disabilities receive the accommodations they need, more work needs to be done in order to address the systemic issues that were raised and ensure that no individual, regardless of their health conditions, should have to live in the conditions that this family lived in.
Thank you for sharing their story, Trini. Really appreciate it. So now, keeping in line with the discussion around housing, I'd like to introduce Amber Villa, who's Chief of A.G. Healy's Neighborhood Renewal Division. She'll talk about what is being done to promote affordable housing and the importance of repairing abandoned homes throughout the state. Amber.
Thank you, Dr. Marshall. So the Neighborhood Renewal Division is one of the newest divisions in the AGO. We've been in existence since August of 2020 and are building on the work of a previous initiative in the office to protect and create safe and affordable housing, which, as we all know, is incredibly essential to all aspects of health and wellness. To achieve this, we are working to transform abandoned and distressed properties into affordable housing in traditionally Black neighborhoods, and working to correct the systemic issues that have denied Black communities access to home ownership and the generational wealth that can accompany it. We are currently working with several entities to create a pilot program to use the receivership process to create affordable housing for first-time homebuyers in the city of Springfield. The City of Homes project is being spearheaded by retired Housing Court Judge Dina Fine and joins the AGO, the City of Springfield, multiple nonprofits, and a group of attorney receivers in collaboration with the Western Division Housing Court to address the critical shortfall of affordable housing within qualified census tracts, particularly in the North End, Lower Liberty Heights, Memorial Square, and the Brightwood neighborhoods, and Mason Square, which includes Old Hill, Upper Hill, McKnight, and the Bay neighborhoods. The pilot will be structured in such a way as to permit participating first-time homebuyers to build generational wealth. It is further intended to address longstanding and structural inequities by increasing home ownership in low-income communities of color, and is designed so as not to encourage gentrification. The pilot is just getting underway. It's expected to last approximately 24 months and involve the rehabilitation of approximately 20 properties for affordable sale to first-time homebuyers. In addition, the Neighborhood Renewal Division is working hand in hand with our Civil Rights Division, Healthcare Division, and Environmental Protection Division to address housing issues that undermine the health and wellness of vulnerable people across the Commonwealth.
Thank you, Amber. And so lastly, we are going to hear from Sasha George, who's an attorney in the AG's Environmental Protection Division, who will focus on environmental justice and the climate change harms that face communities of color. Sasha.
Hi, good morning, everyone, and thank you, Dr. Marshall. So I'll start off by briefly talking about a brief that the Attorney General's Office, in partnership with BU School of Public Health, released in 2020, called COVID-19's Unequal Effects in Massachusetts. And it emphasizes environmental injustice and health inequities across Massachusetts lethally compounding COVID-19's disparate impact on Black and Brown communities, including Indigenous communities across Massachusetts. And so, as we heard Attorney General Healy say earlier, these injustices and inequities are not new. And the report does talk about how, at the time it was released, Massachusetts was ranked 4th nationally in the total number of COVID-19 cases, 3rd in total deaths. And to no surprise to many of us, I'm sure, the cities and towns hit hardest were those that were the home for communities of color, including African American and Latinx residents. And amongst those populations, there have also been historically impoverished and polluted in Massachusetts. And they include having average rates of asthma that are higher in hospitalizations, particularly among children. And so a lot of data that had been compiled for the brief shows that the communities with the greatest populations of people of color in Massachusetts, as I mentioned, included Chelsea, Brockton, Everett, Lawrence, and Lynn, amongst 38 of the largest cities in Massachusetts. And it links it to a study that Harvard released explaining that a lot of the long-term exposure impacts to particulate matter, which is a form of air pollution, relates back to a higher rate COVID-19 death rate. So there's a lot to unpack there, and something that the Energy and Environment Bureau wants to focus on moving forward would be the benefits of developing a more intersectional and critical equity lens in our lawyering as we try to refocus our attention on the need for better community care, as Dr. Charles Anderson framed it so nicely earlier, especially during COVID. And so looking at the way government entities, especially government lawyers at all levels, can mitigate this disproportionate impact and remove systemic barriers in the environmental, public health, but also criminal justice, housing, and other public sectors to better address this urgent need that the community has been so clearly advocating for decades. And this urgent need can really drive the way that government lawyers assess inequity and how we prioritize innovative litigation strategies, but also just general legal strategies that center community leadership, community technical expertise, including citizen science, and the way that community is already self-empowering themselves in their own battle for systemic injustice or against systemic injustice. And so as we're continuously trying to develop and learn about this equity lens as lawyers, environmental, energy lawyers, we really do have to try and focus on a relationship building with these historically marginalized communities. And it should be based on transparency, accountability, and above all else, trust that's been earned or re-earned. And so when we're looking at this relationship and the goals and fighting the community has in self-empowerment, there's this opportunity for lawyers to rely on those goals as a guiding post that can feed legal action. And it would require a cultural shift, which really resonates with a lot of what the panelists were speaking to earlier. And it invites lawyers, not just government lawyers, but also NGO lawyers, lawyers working in institutions, including healthcare institutions, to really decenter this desire to save or help a community and replace it with creative strategy that's responsive to what the community is calling for in terms of action. And so I really appreciated what Dr. Valerie Ward emphasized earlier, which included working on ourselves. And it really would require developing a legal mind that is aware and continues projecting something that many of us, I'm sure, have dealt with or reacted to or learned about, which is called the white savior complex mentality. And I also appreciate what Tonja Santos said earlier, that these issues around health inequities are not just for or about the Black community or our problem. These are issues that all of us have to tackle. And believing that the community's residents are in the best position to strategize and fight for their own liberation and allow for the community's justice to be defined and fulfilled by those experiencing the injustice is really where the direction we're trying to head.
Thank you, Sasha. That was very well said. And I'd like to thank you and Amber and Trini and Maeva for your wonderful presentations. You guys are all so well-spoken. You should be broadcast journalists. And we have our 4 panelists from earlier today that are still on the call, and we have a few more minutes to take some questions. And so I wanted to start with this one, since this is an event put on by the Attorney General's office. We got an anonymous question about how can attorneys, specifically civil legal aid, partner with the medical community to address these inequities, and maybe not just the healthcare inequities, but the other ones that we just heard presentations about. So I don't know if any of our 4 AGO representatives want to tackle that, or our original panelists, but I throw it out there to everyone.
Maybe I'll tee it off just to, because I think one of the things that's happening more frequently, we're doing it here for the Massachusetts League of Community Health Centers, and many of our members are engaged in it. And I saw it even in the Q&A, which is medical legal partnerships, where we're working with organizations to make sure that attorneys are engaging with our health center members in a way that can get people access to resources, can help them navigate some of the many very complex legal challenges that they face within our medical system. And those partnerships are bearing fruit. And I think we're looking to expand those, not just here, but across the country. And I think that, of course, as we say, you walk into a health center, if you have a pain in your side, you go see the doctor at Demick. You walk down the hall if you have to get your issues with your teeth taken care of and get your dental appointment. But we're also now connecting people to an attorney or attorneys who can be in-house to provide those services. So this is all that wraparound that those framers in the 1960s had thought about. I think we can grow it. We can build on it.
And I would just add, I think it is really important that an office like ours and those in government work very closely with members of the legal community and certainly the legal aid community. I do think it requires an intentionality well beyond lawyers. And I think what COVID and the twin pandemics, George Floyd's murder, COVID, revealing to some disparities that have long existed that only worsened during this time. I think collectively, we need to be demanding, particularly, I'm just struck the poignancy of these statistics and these outcomes. And this is Massachusetts, where we are so further ahead when it comes to wealth and prosperity, and yet our people are suffering and dying. It requires, I think, a collective call to all of our networks and everywhere that an intentionality and an equity lens beyond everything that we do. And that means banding together to advocate for legislative changes at the State House, policy changes, investments through budgeting and the like to support these aims. I think encouraging, the philanthropic community as well as the business community to recognize the health and well-being of our families rests on how well the least among us, the most vulnerable among us are doing, right? And so I just hope, while it is the last day of Black History Month, I think it is an appropriate taking off point for this discussion, because this work will continue every day going forward. And I think, I just want to thank all of the wonderful panelists today for sharing what they shared.
Thank you, AG Healy. Anybody want to comment on what she just said before we move on to another question?
Sure. I'd like to say, I really like the intentionality of what AG Healy said. We really need these efforts around health equity to be sustainable. We're going for the long game here. It's not that we're going for the short game. We want to make an impact along the life course of a child. So we know that health equity begins prenatally. And what is the care that the mother or the birther gets? And then what's the care that we're delivering in the neonatal period, in the infancy, and the young child on into adulthood? But let's start early in the life course so we can change the health trajectory of all children into their adulthood. Let's also change the economic vulnerabilities, the educational attainment opportunities. Let's start early. And so really, I like what you said about intentionality, because that's prioritizing health equity at an early age and continuing through the life course. This is coming from a pediatric specialist. So you hear about the life course. That's how we think about adult health. It starts early.
For me, I think some of this is taking a step back. And if we're going to talk about health and wellness, not just racial disparities, we need to look at the big picture. If we're just talking about racial disparities, then as soon as we solve one, there's going to be another one that crops up behind it because we're not dealing with the core issues. So we need to take a step back and look at the structural determinants of health, all of the issues that the AG's office has addressed already, talking about safe housing, affordable and healthful foods, quality education, all of those things that are the backdrop of actual health and wellness, and not just racial disparities and health equity.
Yeah, and I would add that it emphasizes the interconnectedness of all of this, right? And because it's so interconnected, there's no way to solve it just through one channel. There has to be this cross fertilization, this intentional collaboration to bring all of these constituent parts together to address the complexity of what really is health and wellness. It's not as simple as seeing a wonderful doctor. There's a whole range of things that contribute to one's health and wellness experience. And so that's why conversations like this are so important. That's why the partnerships that we talk about are so important. So this is a wonderful kicking off point. You're absolutely right, Attorney General.
And we have a apropos comment from the audience. Yes, moving out of Black History Month and moving into Women's History Month. Tanya, I don't know if you want to sort of comment on, how the two are related or how one bleeds into the other, especially from your perspective.
Man, that's a tough one. We can't necessarily dissect our identities or separate these intersectionalities. And most of the people I work with identify as women, although I use the term birthers to be more inclusive. But we know that, if a society is to be judged by how we care for and wrap support around our most vulnerable, I would say our birthers and children are some of our most vulnerable, especially during the pregnancy and birthing process, then we have a lot of work to do.
Yes, I would add one of the things that actually I think you had some exposure to Dr. Paul Wise as well, didn't you, Malika, back in the day with Dr. Wise and Dr. Zuckerman? One of the things they trained me about was this idea that why is it that women's health starts when women are pregnant, right? We fundamentally are thinking about women's health the wrong way, right? And it gets to this point of the longitudinal journey. Women's health starts as soon as that young girl is born, right? And it's not just about those traditional things we think about in terms of health. It's how that young girl thinks about herself as doing things that require brilliance at age 3 and 4 in a society that often doesn't support that. So it really gets back to how we pull all these pieces together as we think about women's health, men's health, children's health. We have to stop looking at this in silos.
Very well said. I'm going to bring us back to sort of the here and now because we have an important question about COVID. And Tracy wants to know if you have any advice for encouraging unvaccinated Black people to get the vaccine. As a Black female, I'm horrified to hear the reasons people are not getting the vaccine. I was once telling another Black person that they should get it because they could be asymptomatic. And he said, quote, there is no such thing as being asymptomatic. So I'd like maybe Dr. Ward, especially because we're trying to get so many kids vaccinated right now. And then maybe Tanya to sort of talk about your experience trying to get pregnant women and children the vaccine.
Oh, thank you. Thank you for bringing up this important question. This question embodies the complication or the complex issue of knowledge, information, dispelling myths, getting the correct information out to the community. And so when someone answered the question about the vaccine that was incorrect, we as health systems, we want to address that. And what we did at Boston Children's is we opened up the opportunity to get the vaccine, not just to children, but to their parents, to their families, and their communities. We thought that if we could get information out to the community by way of the child, okay, we would only increase our efforts at getting children vaccinated, would get the communities vaccinated. We did something else I'd like to share. When we talk about listening to the voice of the underserved and the underrepresented, we ran focus groups at Boston Children's with our underrepresented employees who were reluctant or hesitant to get the vaccine. And we said, let's hear it in your words. What are the barriers? Information. And our hospital being a trusted source of that information was a recommendation from our underrepresented employees, the ones that would not get the vaccine. And we got to vaccine acceptance. So again, really trust of our health systems, that's on our side. We need to do the work in the community so that they will trust, our communities will trust us. And we need to bring the information. Can't stress that enough.
Thank you. I took my kids to Children's to get their, I don't know, their second shot or their boosters. And I was so impressed to see that they were offering it to grandparents and parents who were there with their children, and they were taking advantage of it. So that warmed my heart at Children's Hospital. Tanya, anything to add?
I think pregnancy is a particularly challenging time to offer people vaccines. So they have their baseline hesitancy perhaps, and then pregnancy adds another layer of hesitancy. But I think, as Dr. Ward said, information is key. So being open and honest with what we know, being open to what people's actual concerns are rather than assuming what they're concerned about can get us a long way. And then, sharing my own personal experience and disclosing that I'm vaccinated and the reasons I get vaccinated, I think is helpful. And then if they don't want it in pregnancy, tell them that we're happy to give it to them right after the baby's born, if that's better.
I totally agree with you, Tanya. I remember learning in medical school, like you should never really talk about your own personal life and health when you're talking to patients. And I have thrown that out the window because I find one of the most impactful way to reach patients individually in an exam room or even on television is to tell them about your own personal experience. And I think they become much more trusting. So I think on that, we're going to have to end this discussion. It concludes today's convening on Black health and wellness. And I want to wish you all the last few hours of Black History Month as happy as possible. And I hope that you've learned a lot today and that you take it back into your communities to make them healthier and happier and more productive. And with that, I'm going to turn it back to April.
Thank you so much, Dr. Marshall, and thank you to our incredible panelists, our great AGO staff, and of course, our phenomenal Attorney General for this important discussion today. We thank all of you for joining us. As Dr. Marshall said, we hope you heard something helpful and useful that changes your life going forward. Be well, and please enjoy the rest of your day. Take care.